Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamconda.
Welcome to Always On EM, an emergency medicine podcast from Mayo Clinic. My name is Venk Bellamconda.
And I'm Alex Finch.
We're thrilled that you're joining us for this month's chapter. We talk about risk frequently in our clinical work. The most important risk, of course, is for adverse events to our patients, risk of death, risk of disability, risk that we are just not meeting the patient's needs from the emergency department visit. At least relatedly, if not identically, there is a legal risk that we should be aware of. To that end, we are eager for today's discussion on high legal risk situations in emergency medicine. There are some standout people in this space where medicine and law intersect. Our guest today is a standout among the standouts. Her name is Dr. Rachel Lindor, and she is an associate professor of emergency medicine at Mayo Clinic with experience in leading the specialty in Scottsdale, Arizona. Shout out to our Mayo brothers and sisters in the Cactus Country, where she was previously the chair of research for that department and then also the director of the research fellowship. Currently, she is spreading her wings in the research group here in Rochester, Minnesota. In addition to her standout EM career, she also graduated second in her class of nearly 200 people at the Sandra Day O'Connor College of Law and is a skilled attorney. She is frequently invited speaker at national, regional, and local levels, such as at ASAP. You should definitely drop in and listen to her speak if you're there. And she has published several times on aspects in this space of overlap between the two disciplines. In fact, she has close to 50 publications in her still very young career. She's a great teacher, colleague, and friend, and we are very grateful that you're joining the show.
Thanks so much, guys. I'm happy to be here. This is one of my favorite things to talk about, so excited to get going.
Those were a lot of credentials, but for me, it's much more simple. Rachel was one of my seniors when I was an intern, and so I just know her as the person I go to when there's a big problem. I got to find Rachel, get the answer.
Yeah, thanks. We'll see about that.
I guess it spans the gamut, right? Because I was there when you would shadow Dr. Sadosty in the department, and now you're talking about how she was teaching you. That's pretty cool.
Absolutely.
But, well, welcome. You have obviously built quite the credentials in this space, and so as a topic that I think scares most of us and is really interesting that we want to avoid, we're really excited. To that end, what are the most common diagnoses that lead to malpractice claims?
We often talk about this in forms of the most common diagnoses because that's one of the only areas that we have actual objective numbers to go by. So I think it's useful. And you can think about it in terms of most common diagnoses for physicians seeing adults or for kids. So for adults, it depends on what study you look at, to be honest. And usually the way that we get these numbers is looking at studies of large insurance claims databases. So when you do that, the most common diagnoses that come out are generally cardiac arrest, which they differentiate from just MI, aortic aneurysm, PE, appendicitis, and orthopedic fractures. Those tend to be the same ones on every list for adults.
Does that mean if I don't make this diagnosis, then my chart's fine? I'm protected? If I just say chest pain, I'm good?
Yeah, I think that's what she's saying.
Okay.
So generally, when you think about high-risk diagnoses, that's usually what we talk about is just kind of those main things. And you might extend that list out, but actually, and this jumps ahead a little bit, but when you add up those numbers and look at, of all the lawsuits that we're seeing, if you look at the top 5 diagnoses or even the top 10 and you add up what the percentage of the total, think about the top 5, it actually ends up being only about 20% of the total lawsuits in any given study. So if you made it your goal to say, I'm never going to get sued for those top 5 or 6 things, you're really only hitting the top of the iceberg, so to speak. There's utility in focusing on those, but it's not going to protect you as much as you think it will.
That's so interesting.
Are the top 5 the same for adults and children? You kind of alluded.
There's some overlap. You'll see overlap with cardiac arrest and appendicitis and orthopedic fractures, but those are all the same on the kids list. But then you also tend to see things like testicular torsion and meningitis for pediatric patients as well.
Rachel, I don't have a perspective on what these cases might actually look like. Are you allowed to share any examples?
Yeah, happy to share examples. So these generally come from legal databases, which are theoretically publicly available, although usually they're subscription-based. So unless you're willing to pay a lot, you can't dig into them. But I can give you some examples of any of these. So resuscitation-based cases were the number one cause of lawsuits in the adults. And so if we want to look at a few of those, I have a few that I have tended to focus on because I think they give us some ideas of good themes. So there's a case from Florida that was from 2004, which I think gives us some things to think about. And this one, there was a 2.5-year-old boy who was out playing in his backyard with his dad, who was doing some gardening. And his dad looked down just in time to see him get bit by a diamondback. So his dad knew this was going to be bad. He called EMS. EMS got there. They brought him into the hospital. But by the time they got there, the kid actually looked okay. So they just said, well, he seems to be doing okay. We'll see how this goes. Just kind of watched him. As time went by, over the next couple hours, he started to get more symptomatic. So they decided we should probably do something. But they had a really hard time getting an IV. So they were kind of trying to get an IV, had a lot of difficulty with it. Finally, he was really starting to deteriorate fast. So they decided they had to do a saphenous cut down. The little boy codes. They're still working on the saphenous cut down. They take 10 minutes to do this, finally get access through it that way. The boy's coding the entire time. They eventually get access, give him meds, etc. But presumably because of this delay in access and everything else going on, he gets pulses back, etc. But he eventually ends up brain dead. And family sues and says, you had an IO there. Why didn't you use it? And they didn't really have an answer. I think this goes to show that family might not have been savvy enough to know that there was another form of access there, but lawyers are certainly savvy enough to know kind of what should be happening in these resuscitation cases. They're going to look at all the details and kind of hold you to the standard of care. And there was an IO in the resuscitation bay and it just wasn't used. And they spent 10 minutes without access for this kid. So that's one case. Another case, I think you'll see kind of similar themes. So a male patient, middle-aged, came into the ED with chest pain, shortness of breath. He had an EKG done, but nobody read it for about 30 minutes. About the same time that it was read, 30 minutes later, it showed an MI, patient coded. And he, went through the code, and during the code, he was never given aspirin, and then they were charting when they were giving epi, but it wasn't at 3 to 5 minute intervals. There were delays in that. The patient ended up not dying, but having some permanent cardiac issues, and his family sued, saying the delays in EKG interpretation, aspirin administration, and epi administration resulted in his deficits. And again, families probably don't know what exactly should be happening in that code, but the lawyers who take up these cases know. And I think understanding that we're being held to these standards during resuscitation is important. I think we have a tendency to, when somebody codes, pat ourselves on the back if they don't die. But we have to expect more from ourselves than that. We have to expect that we're crossing all the T's and dotting our I's appropriately. It's not just, did they make it good on us?
I think that's such an interesting one for me because I also think a little bit about cutting edge resuscitation, and I'm not sure that there's a right answer, but I'd love to get your perspective. So there's some discussion about using less epi in codes and using other kind of non-standard techniques, starting a beta blocker for refractory shockable rhythms. And these are all really interesting, but some of them aren't in ACLS. How does a lawyer look at that if you decide, oh, well, I'm not going to choose to do epi because, I think that the evidence shows that there isn't a good neurological outcome, even if there's improved ROSC. It's something we debate a lot, but I'm not sure how it would look to somebody looking over the case later.
You could peel that out and ask a couple different questions. You could ask about, so how does it look if you depart from the very clear standard of care that's written in ACLS and, don't do the thing that's been done for 30 years or however long? Yeah. I think that's kind of easy fodder for a lawyer. You can go argue there's no mortality benefit, look at all these studies, but that's getting really into the weeds. And then you're relying on, a jury of lay people to care about your studies that you're showing them versus like decades of standard of care. I feel like that's a really risky practice. And so until some guideline came out saying this is now the standard of care, I would not recommend going there. And then there's also the question of, there's these new things like, okay, standard of care is not working. Can you try?
She's talking to me. She's saying ECMO. She's speaking directly to me.
Can you advance beyond that and try these other things? And I don't see lawsuits about people kind of going beyond the standard of care and trying new things are not as common for a couple reasons. First, you're generally doing that on patients in whom the standard of care is not working. Second, those scenarios are ones in which I think you can see that you're not being cavalier in kind of advancing beyond the standard of care. You're not holding back something, you're trying something additional. And so that's a harder argument for, say, a plaintiff's lawyer to make, that, you were doing something wrong. And it seems to like a jury of your peers or lay people that you were kind of going above and beyond. So I think lawyers are less likely to kind of try to make you out to be a bad person if it looks like you're doing extra.
That's such an interesting perspective. I really appreciate that. These cases, I think something that's challenging about them is all of us can see where a problem occurs, but also you can see a reality of, hey, the epi didn't go in, we were doing something else at that moment, or by the time the patient codes, we forgot to do the aspirin. Those things happen around us at times. And so these are such interesting cases because you can both pinpoint the problem, but also probably admit that there have been cases in all of our care where it didn't go exactly like we wanted with these benchmarks.
I suspect that one of the reasons resuscitation cases are so common is that there is such a black and white standard of care, and it's very easy for lawyers to look at the chart and say, was it met or not? Whereas in, so much of our other care, there's nuance, and lawyers are not physicians. They weren't in the room. They really don't know what happened there. But with resuscitation cases, it's pretty clear this is what should have happened. If there was a departure and there was a bad outcome, it's easy to say, let's try our luck with that one.
You talked about a few examples of resuscitation cases. Can you share an example or two of MI case and a PE case?
Sure. There are so many of these. It would take me so long to even get anywhere down my list of these, but I, again, tend to look for some that give us some themes to think about. So one of my favorite ones is a patient who was a 45-year-old gentleman. He had some type of kind of advanced neurologic cancer, and he went into the ED with confusion. So everyone expected this was some expected sequelae of his known tumor. And in the ED, at some point, somebody ordered an EKG on him, as happens. Wasn't the physician, probably a nurse order or something. He ordered an EKG. And so he had this EKG done. Nobody really paid any attention to it. The computer read it out as an age indeterminate MI. He ended up getting admitted because of his confusion, treated in the hospital. He was in the hospital for a few days, discharged, and 3 days after discharge, he died of a fatal MI. And his family sued and said, look, he had this EKG that said age indeterminate MI. Nobody asked him about chest pain. Nobody got a troponin. It was just completely ignored. And there was no documentation about anything cardiac related, despite this, questionable cardiac finding. The ED doctors tried to say, we didn't even want that EKG. But there it was with this finding and no documentation or follow-up on it. And there was a $6.3 million verdict for that patient.
$6.3 million.
Mm-hmm.
And infarction, not ischemia.
Right.
Wow.
So, I think the take-home point there is you don't have to get a troponin on everybody, right? But I think if they would have just documented he had this EKG, he's not having any chest pain, or other symptoms, we don't think a troponin is warranted at this time, we're not concerned, whatever. I think that would have prevented this case from happening, but there was no documentation. And again, people looking at jurors, courts, looking at these cases sometimes really are offended by errors of omission or, this feeling that physicians just didn't care. And if you don't document, you don't acknowledge, it's really easy to read into that the people providing care for this patient didn't care.
I'm going to have to spend time after my shift reviewing all the EKG final reads. Is that what you do?
It's maybe what I should do.
Especially since there's a prelim read. I mean, there's a computer read, then there's the tech read, and then there's a cardiologist read eventually.
I try to be very thoughtful about who gets EKGs. That's probably how this has changed my practice.
That's interesting because I've always just said it's a harmless test. We should get it. But this is eye-opening.
Yeah. So another one, 53-year-old guy comes into the ED with chest pain. He gets an EKG, chest x-ray, a troponin, and a CTA. All of those are normal. So normal EKG, normal chest x-ray, negative troponin, and a CTA is all normal. 27 days later, he has an MI. And he sues, saying, I should have gotten a second troponin. it's unclear from the documentation how soon after his chest pain this first troponin was. There was no documentation of it. And this one ended up in a defense verdict, but, you know, it went through court, years of court process. And I think my takeaway from this is that, again, not everyone needs a second troponin, for sure. That's not what I want anyone to hear from that. But that you just have to be thoughtful about your documentation. If you're not going to get a second troponin, that's great. I'd say most of my patients don't get a second troponin, but you have to document why. You know, his chest pain started however many hours before, whatever it is, document it. Because otherwise, it's, again, easy for a lawyer to look at and say, oh, the protocol is a repeat troponin. It didn't happen. I'm going to try my luck with that. You know, once you go to court, it's a coin toss. So that's one sentence, 10 seconds of your day to say why they didn't get a second troponin.
I think a theme that's starting to show through is when there's a clear guideline or a clear rule, you can certainly deviate from it, but that's where you might spend attention in the chart. So if a 2-hour troponin is going to be drawn as part of the hospital process and you choose not to do that, that's worth an ED course update saying chest pain started more than 6 hours ago, not clinically indicated this time.
Yep.
Okay. Let's stay in chest pain because now I'm just getting more and more anxious
about
my last
chest pain.
I'm feeling chest pain.
Perfect.
It's non-specific.
Okay.
It started more than 6 hours. No, it started in the last 5 minutes. But what other stories do you have for us?
This one was a female who came into the ED with chest pain. She also had a normal initial workup, so normal troponin, normal chest x-ray, normal EKG, but her story was suspicious, so the doctor decided that they were going to bring her to the hospital. They were told she was going to have to board in the ED for a little bit, so doctor communicated to the nurses, if she has any recurrence of pain, just get a repeat EKG and let me know. She ended up sitting around in the ED for quite a while. About 3 hours into her ED boarding, she did have some recurrence of pain. Instead of getting a repeat EKG, the nurse gave her some Ativan, I guess by nursing protocol or an order that was already in. Did not get a repeat EKG. About 6 hours after she was initially boarded, she did get admitted up into the hospital. She was still having chest pain at that time, had an EKG done at that time on hospital admission, and had just a rip-roaring STEMI. She ended up having, really profound heart failure from this, pretty severe deficits, and she sued, had a $3 million verdict. And my takeaway from this is, first of all, this is a problem that people are dealing with more and more. It's boarding of our ED patients, and you really can't hand off the patient to nursing staff. It's your patient ultimately. And so to let that patient go for 6 hours without checking on them, I think is asking for trouble. You can have all the protocols you want, but I think ultimately you have to have some ownership of them. And obviously this was kind of a Swiss cheese model where there were multiple errors made, but I think really owning those patients while they're in your ED is really important. And you can see where that can go really wrong, get you in trouble.
Certainly there's other factors to weigh in, but our current model now has patients who are boarding after a certain period of time are then owned by the inpatient team, even though they're physically in the emergency department, and we're not labeled on them or notified of anything anymore. How do you weigh that in a scenario like this?
Right. And I worked in a place where there was a similar model to that, and I think that's a risky model, to be honest, because I think that those patients are in danger of really not being owned by anybody, because if the person who owns them is 3 floors away, I think they're less likely to get acute care when they need it or have their needs communicated. And I would still say if they were your patient and they're in your ED, you don't get to wash your hands of them. And I would make it a point to walk by and just check on them, because if something happens to that patient, 100% chance you're going to be named in that suit and you're going to get dragged into that suit. And if you say, hey, by hospital policy, I wasn't responsible anymore, I think that argument is really unlikely to save you. Maybe, but I wouldn't count on it.
And at the very least, we'd be in a lot of pain for months.
Oh yeah,
and months going through the
years.
trial.
I mean, these take years, right? Years. So you're going into that lawsuit. Whether you get pulled out of it because of this policy, maybe, but does that really, prevent the heartache?
I think that's really interesting, because a lot of times these policies are developed with an intention of developing a very clear chain of command, which I think is a good thing to try and minimize errors. So, but at the same time, we have situations where the nurses are more familiar with us, so might come to us with a question, and in a good-natured way, we might say, hey, there's like a clear chain of what should happen in a non-emergent circumstance. That's probably the safer thing. And I think that it's so interesting to hear about things a little outside of our specific hospital lens, right? How would somebody on the outside look at this and say, well, you still got a question and you might have deferred it to the inpatient team, but you were asked a question. And it's always a very interesting thing how complicated these things become quickly.
Yeah. And I think ultimately, this patient was sick enough to come into the hospital. They're sitting in your ED for however many hours. You're trying to do the right thing for the patient, popping in and just saying, you're doing okay, you're still not having X, Y, or Z symptoms, whatever you're worried about, is the right thing for the patient. And as long as it's getting communicated to whomever it needs to get communicated to, that's what it's coming down to, is taking care of the patient.
So we've had a couple of interesting chest pain type questions. There was resuscitation, and did they get the specific steps in the guideline? There was a test that was done that may have been missed or not interpreted. And then just now there was kind of a delegation. How about misdiagnoses?
For chest pain or MI?
Yeah.
So many. So, the classic misdiagnoses for chest pain is patient comes in with GI symptoms and we just decide not to go down that pathway at all. And I think that there are cases where maybe that's justifiable, but you have to understand that you are taking a risk when you're doing that and to be very thoughtful about it. So, to put some color on that, I can give you a case from Oregon, a 44-year-old guy who went into ED, and he basically complained he was having pain in his arms, some chest pain in the back of his tongue. He was seen by he's seen by a PA and staffed with a physician, and they decided this sounded like acid reflux, primarily because of the pain in the back of his tongue. And then maybe he also had some underlying neuropathy causing the pain in his arms. So they prescribed him Pepsid and prednisone.
For the neuropathy, maybe.
I don't know.
Interesting.
They sent him home and said, if your symptoms worsen, if the Pepsid and prednisone don't cut it, go back to the hospital. And he was found dead the next day in his home and had an autopsy that showed that he'd had a fatal MI. His estate sued and saying, you guys didn't do anything. This was clearly an anginal equivalent. You didn't get an EKG, you didn't do labs, you didn't do anything. And they settled it out of court. So we don't know exactly how much money it went for. But there are so many cases like that where we just think clinically, we're pretty sure this is a GI thing. We're not going to go down that pathway.
We don't have access to their documentation, but if they had documented, here's why I don't think this is ACS. And we talked about this with the patient and whether or not they wanted to go get an EKG with this low likelihood, and they said no. Would that have likely changed some of this?
So having seen a lot of cases like this, it can go both ways. So when you engage in some shared decision making and the patient declines, most of the time, it will still often go to court. I'm still seeing those cases come through where the patient goes and has a bad outcome, they sue, or the family sues after they die. And the argument is, we talked to the patient about it, they declined, they didn't want to do these things. And then it ends up being a verdict or, some type of outcome for the provider. But it's still going to court. I think in these cases, it's important to be the physician and provide a little more guidance than to put it on the patient's shoulders, if that makes sense. Like, this isn't one where it's like, it's a coin toss. It could be GI, it could be your heart. What do you want to do?
I'm very much in the learning phase, but I think you start to see shared decision-making being this huge spectrum. And it's been interesting to be a learner in this space and say, is shared decision-making, we have two options and we could kind of do either of them? Mm-hmm. Or is it, well, I recommend this option, I think this is the better one, but you have autonomy and here's why we may or may not do these things. And you can see how even introducing direct language like, I recommend this one, is different than, we have a couple of options before us. And so I don't know how those nuances work, but I can imagine that even on the spectrum of shared decision making, there's a lot to unpack.
I think in the second example you gave, it's more a discussion of medical advice and somebody saying they don't want to go with the medical advice versus, I believe you're right, that shared decision making is supposed to be when the options are equivalent, and maybe we overuse it when things are not truly equivalent.
Right. I think sometimes we can slip into it in this because clinically these are tough to decipher. GI, cardiac, but that doesn't mean that we get to put that clinical decision making on the patient, right? Like then we have to decide, well, one is this high risk, potentially fatal thing, and one is not. So I would say we should err on the side of testing for the potentially fatal thing. And we're not talking about tons of testing here for the most part. It's troponin and EKG, and if your pretest probability was not super high, most of the time you're done there.
Really insightful.
I agree. So Rachel, to this point, we've talked about resuscitations, MI, like these really big, scary things. But what about some of the other more commonplace conditions? Do we ever get in trouble for those?
Sure. So the other things that were on that list that we haven't talked about yet would be things like appendicitis or orthopedic fractures, and we get in trouble for those all the time. They're on the list. So I can give you some examples of those. Probably my favorite appendicitis case, or the one that I think is most important to highlight, is one of a 39-year-old female who was seen with abdominal pain, and they were worried enough about her that they did an ultrasound, they did an x-ray. Both those were negative. Not really sure what they were looking for with the x-ray, labs and such, and then they decided that she could be discharged. They didn't see the appendix on the ultrasound, to be clear.
Ooh, the dreaded appendix wasn't visualized, maybe no secondaries. Oh, that always...
But they got enough reassurance from it that they sent her out. And they did see an ovarian cyst. So sent her out, and 3 days later, came back, found ruptured appendix on CT. So the reason I want to highlight this case is I see this all the time from trainees where we get an ultrasound and they say, oh, she has a cyst. And I think the teaching point here is that, the normal ovulatory physiology is to have cysts. That's what fertile females have, ovarian cysts. And so when you see that, that should really mean nothing to you. But people want to anchor on that and say that's the cause of their pain. Unless you're seeing it like actively hemorrhaging, you're not done with your workup. And that seems to be what happened here, and it led them into trouble. And so that's one thing I just want to highlight with this case. And why the reluctance to get a CT, I'm not sure, but appendicitis is on the list for both adults and kids, and you will get sued for missing it if you're avoiding doing CTs throughout your career.
So we're part of the way through the interview, but I realize I'm already behind. When we're thinking about the elements of a lawsuit, what has to be there for something like this to move forward?
So generally we think about 4 different elements of a lawsuit for a malpractice suit. First one is that the physician has to have some type of duty to a patient.
So right-click, assign me as the provider. I'm in. I'm all in.
Actually, I think I've heard, maybe I'm wrong, as soon as they enter the parking lot, we may have a duty to them.
Right. In the emergency department, when they become a patient, which technically is within 250 yards of the ED, there's implied consent that they're your patient. So you have a duty.
Okay, duty.
All right. And then you have to breach that duty, or you basically don't perform your duty in some way. So you have a duty to provide them the standard of care, and then you have to violate the standard of care in some way.
And we've been going over, the guideline says they should get epi, and I didn't give the epi. So I breached the duty. Okay.
Yep. And then that breach of duty has to cause them some type of harm or injury. And then the last element is that your breach of duty has to cause some harm or injury that's kind of measurable or objective.
Okay, that makes sense.
So duty, breach, cause, harm.
All right. Now I have a formula for my fear. I like it. So that was a great API case. You mentioned ortho.
Right. So ortho is another one of those areas, usually missed fractures that I think we kind of take for granted as high risk cases because they aren't cases in which patients are dying, but they do lead to permanent disability. So I think we underappreciate how important these are to manage appropriately, and we get ourselves in trouble there. So I can give you a couple examples of these. First one is 85-year-old male in Oregon, basically fell down, had a mechanical fall. He ended up coming in with some back pain, flank pain, right around his rib cage, basically. So he had a chest x-ray and it looked okay. And so he was discharged home with, lidocaine patch or whatnot. And 2 weeks later, he came in, basically had been kind of slowly suffering at home, came in respiratory distress, and ended up dying in the emergency department from a massive hemothorax from undiagnosed rib fractures that had lacerated a pleural artery. This is a really dramatic example, but basically highlights the fact that X-rays for rib fractures in the elderly are not an appropriate test at all. The sensitivity for those are about 40%, and it shouldn't be used. And so I think, the theme that I want to highlight as we go through however many cases we'll get to in this is that you really have to understand the sensitivity of X-rays for the test that the injury that you're trying to identify. And so X-rays for rib fractures in elderly people cannot rely on. This patient should have gotten a CT. It would have diagnosed this in the first place, and this wouldn't have happened. Absolutely avoidable. Talk about another case that kind of highlights the same thing. And this one, a 37-year-old female got out of her car. She basically tried to step over a curb, missed it, face planted, fell right on her face. She happened to be right outside of an urgent care. So she went into the urgent care, and the urgent care doctor said, I'm sorry, all I have here is x-rays, and those are no good for you. So you've got to go to the ED. Well, the ED physician x-rayed her face and went to the radiologist, who said no evidence of fracture there. And so she left. Her jaw was kind of never the same. She couldn't chew, was just not moving right. So 3 weeks later, she went and followed up with an ENT doctor who did a CT of her face, and she had a really displaced bad mandibular fracture. And she sued both the emergency physician and the radiologist. And what came from that is they found the emergency physician was at fault, but not the radiologist, because what came out in the trial was the emergency physician should have known better than to get the mandibular x-ray, which is only about 60% sensitive for fractures. It's not the radiologist's fault he couldn't see it. That's just the truth of a mandibular x-ray. But it's the emergency physician's fault for even ordering it. And again, the theme being you need to understand what you're looking for and the utility of x-rays for doing that. And, we could keep going with x-rays for hands and feet. They are not very sensitive. If that's all you have, then you need to be immobilizing and getting appropriate follow-up. But to rely on those really puts you in a really risky area. So understanding the limitations of your tests, especially when it comes to orthopedic fractures, will save you.
That sounds like it's also a good example of how when she fell on the property of the urgent care, there's a duty automatically there, right?
Generally, there's no duty to urgent cares. It's an EMTALA mandated duty, and most urgent cares are not.
They're exempt.
Yeah.
We're in the wrong specialty.
Okay, so now I have a series of complaints that I'm worried about. Let's talk about some situations where I'm trying to navigate higher risk situations regardless of what the chief complaint was. And I'm thinking about things like against medical advice. Those are things that we all encounter on shift. What's the best practice for those types of situations?
Sure, these are complicated, and I think we all recognize that these are high-risk patients. We've been taught about this since our first years of training. I think it's helpful to think about these patients in two different categories. They're the patients who want to leave against medical advice that you're actually worried about, and then there are the patients who are just want you to see them faster, and they're threatening to leave against medical advice, and you're kind of okay with that. They're both high risk, and they pose different types of risks, but I think it's more useful to think about them separately. So the first of those groups, the ones that you're worried about their actual pathology. First of all, we have to recognize everybody has the ability to choose what they want to do. We'll start with that premise. People have the ability to choose what they want to do with their own bodies, make decisions for themselves. asterisk, assuming they have capacity to do that. And I think we have to be really careful and better about documenting people's capacity to make decisions to go against our medical advice. Absolutely, people can leave against medical advice, make decisions that we disagree with, but we need to be sure that those patients have the capacity to do so. And we are really bad at charting that and documenting it. And that's one of the first things that I think we can do to protect ourselves in those situations. We are so used to having them sign a form, and most of the time when you look at those forms, they don't say anything about capacity. I tend to not have them sign a form at all because I find them to be a bit antagonistic. But I do spend a lot of time, relatively, talking to them about capacity and documenting that, because I think that's absolutely the most important thing in that discussion.
So what kind of language are we talking about? Option A, I think that the patient has capacity to make this decision. Or option B, something else.
So option B, something else. But I will say, when I've looked at these cases, I've never seen a case about capacity where there was any documentation in the chart about capacity at all. So option A might protect you.
Okay. All right.
But it's not appropriate.
So there's a chance. We keep coming back to this.
All the cases I've seen, they basically alleged there was no attempt to assess capacity. So we're just not doing it. But option B is the right answer. And I think we've all heard this. There are 4 elements to capacity. To be honest, I look them up every time. Even though I talk about it all the time, I haven't retained them. They just aren't intuitive to me. And every time you look them up, authors word them in a different way. They use different vocabulary to talk about them. So what I would encourage you to do is understand when a patient needs to have their capacity documented, go Google the 4 elements of capacity, write down what they are, and take them into the room, and then figure out, okay, does the patient understand the information I'm talking about? Are they able to retain it long enough to communicate a decision to me and to reason and weigh their choices? Those are kind of the 4 elements in general. So understanding, retaining, reasoning, and communicating. That's kind of the 4 in a nutshell. Different authors will word them in different ways. It doesn't really matter. If you've made the effort to understand what those 4 are, talk to the patient and assess each of those 4 elements, and then go document those 4 in your chart, I do think that's protective of you. It's protective of the patient. That's the right thing to do. But I don't see that being done. And I think that's so much better than any AMA documentation I've ever seen.
This is a great time to just direct the listeners, especially we've had so many newer listeners since we released chapter 3 of our podcast overall. It's called Capacity or No Capacity. That is the question. And we go into a huge deep dive on that. And it's not from the legal perspective so much as it is from a psychiatric perspective or from the medical perspective. And in there, the only other part, and I'd love your opinion on this, is I advocate that before you even begin, you have to assess how high risk the situation is. And if it's a really low risk situation, like I want them to have apple juice and they want milk, who really cares? You don't need that much evidence. But if it's a much higher risk that I want them to have TPA for their acute stroke and they don't want it, then I'm going to have a higher standard of factual evidence or justification for each of those 4 elements before I would agree to it.
Yeah, I think that's absolutely how capacity is taught. And, you assume everyone has capacity, and then basically you're looking for evidence that would reverse that assumption.
You need a lot for low risk, and you don't need much for high risk situations to reverse their assumption that they have. While we're on the topic of capacity, things that I commonly see are that people will say the patient's alcohol level is 300, therefore they don't have capacity. How does that resonate or not resonate with you from a legal perspective?
I think we're all familiar with patients who are functioning alcoholics and have an understanding that alcohol level doesn't really have a strong association with people's ability to understand, retain, reason, and communicate. So you can definitely do a capacity assessment independent of somebody's alcohol level. As long as you're documenting it, that's what's really important.
I just wanted to get some validation because sometimes I feel like I'm the only one preaching this, and coming at it from a different training background, that really helps. So it sounds like we're completely aligned. And so check out chapter 3, season 1 of the show where we take a deep dive on this.
A couple other things where I do see people go wrong. I think there's a tendency to get frustrated with patients, especially these ones that you're really worried about who want to leave AMA or choose a path that you're not recommending to them. And, when they do that, say, sign this form and good luck to you. And it's really important that you're not taking that path. You're not kind of making it personal. And that if somebody is deciding to choose their own way, that you are doing what the literature says, and I would say is the next best plan. So you think they need to come in for IV antibiotics, they don't want to for whatever reason, that you're not just saying good luck, but you're making a plan to give them oral antibiotics or bring them back for follow-up the next day or whatever it is, whatever they will put up with, show that you made an effort to give them the next best care that they would agree to. And if it's truly nothing, you document all your efforts to do it. So for those patients that you're really worried about, not only are you documenting their capacity, but you're documenting, kind of the entirety of your discussion about what their reasoning was and what efforts you made on their behalf. And then, we talked about that second group of patients, the ones that you're not really worried about, but they're going to leave anyway. It's tempting to just say like, okay, I'll see you later then, and stop thinking about them because you weren't worried about them anyway. It's like a relief for you. But I think the danger of that is that sometimes those patients will come back to bite you in sneaky ways. And so you really have to be cognizant of the fact that you still own that patient, even if they're gone. And maybe they're partway through their testing. They've had labs drawn, they've had images done, and you still have to follow up on those because ultimately, they came there for a reason. They have results pending and you own those results. And so there have definitely been situations where there were incidental findings or lab results that didn't get communicated to the patient, and then the physician or provider got themselves in trouble because they didn't follow up thinking that patient was gone. And that's not true. That patient's still your responsibility.
Just as we did with the other topics, can you bring any real examples of AMA-related lawsuits so that we can really make this come to life?
Yeah, I have a lot. So I can give you a case. A gentleman who came in with a concerning headache. This was a Florida case. Basically came in.
So Florida man.
I don't know what that means.
That?
No.
Oh, later you should Google Florida man.
Okay. Came in with a bad headache. Right away, the person that was really suspicious for a subarachnoid. He consented him for an LP. It's unclear to me if he did a CT or not, but doesn't really matter. Consented him for an LP. At some point, the patient said he declined and said, you know what, I'm just going to go home. I don't want it after all. So physician was still worried about him and had him sign an AMA form saying, I understand that I could die, whatever. So he signed the form, went home, was found dead. And family sued saying he must not have really understood that this was dangerous. Like, we don't know what you said to him, but he's a very reasonable guy and he would never have gone home if he realized he could die. And went to court and there was a $9 million verdict. There was a signed AMA form, but there was nothing else in the chart about the discussion. And I think it highlights that this form itself cannot be relied on. It's not enough. Look at your AMA form next time and see what's on it. It's like a checkbox and a signature line, and that's it. So it cannot be relied on. Similar case, Illinois, a man came to the ED. He had a chest pain, an EKG that had some signs of ischemia, not a STEMI. And his physician wanted to admit him, work him up as such, and he decided he wasn't really a good time for him. So he went home. Physician had him sign an AMA form, said you really got to come back. At the very least, you have to follow up within a week and get this taken care of. And he didn't, and he died at home. His family said the same thing. I don't know what you said to him because it's not documented, but clearly you didn't communicate this well enough. There was a $5.5 million verdict in that case. Interestingly, in that case, the jury said, we see your AMA form, and we're going to take this $5.5 million verdict, and physician, you're half at fault, and the patient is half at fault. And that's how they use that form to apportion fault. I mean, I could keep going with those, but I think you get the point that these AMA forms alone are not sufficient.
It sounds like it's the documentation of the conversation, first having the conversation, and then documenting it thoughtfully is going to be the most important. So we talked about more on the patient where we're worried and they're leaving against medical advice. But I bet there's some potential risk in the patients, like you mentioned, that they left because they didn't want to wait any longer, and we have outstanding test results and things. How do we approach that?
So these patients also can pose a challenge to us for a variety of reasons. I can highlight some of those with some cases. So one of these cases is from Massachusetts recently, just last year. In this one, there was a 47-year-old gentleman who came in as a trauma evaluation. He had fallen off a roof, and so it was a big trauma alert. He got CTs of everywhere, including his chest. And from a trauma standpoint, I don't know what injuries he had, but one of the reads showed that he had a pulmonary nodule. There's some conflict over whether or not he was ever told about his pulmonary nodule. He had a hospital stay related to his trauma. He was ultimately discharged. About a year after that discharge, he developed liver metastases and then was subsequently diagnosed with a lung cancer, and he died a month after that. He went back and sued the initial trauma team and said, "You guys never told me about this lung nodule." And they said, "Yeah, of course we did, but it was never documented." He sued, and then after he died, his estate continued the lawsuit and got nearly a $6 million verdict for, failure to communicate that lung nodule. And you can see how easily that would happen. I mean, he was a trauma eval. This was not about the lung nodule in any way. And I think this could happen to anybody. This wasn't quite the example you gave where a patient left early, but that could happen to so many of these patients who left early. If you don't have a system to call these patients back and let them know about things that were probably irrelevant to their ED visit, but potentially relevant to their lives in 10 years, you're absolutely on the hook for that.
That makes sense. And so much of what we're talking about revolves around discharge. So what in general advice do you have for us when we're discharging patients, especially in these unusual or irregular circumstances?
I think discharged patients, which is a lot of our patients, make up another high-risk category that we take for granted, because unlike patients that are getting admitted and you're handing off their care, for this group of patients, we're the only ones that are owning their care. And half the time, we have no idea what's going on with them, right? Like, we don't know. They don't have a diagnosis. They came in with symptoms. We kind of looked for the emergency things, and then we tell them, "You look okay today. We don't know what's going on, but you look okay." So I think one of the issues that we see over and over again and the allegations is that we missed the diagnosis. One of the ways we can avoid missing the diagnosis is to not commit to a diagnosis on the discharge instructions. We see that a lot, right? They come in with some vague abdominal pain and we call it gastritis or we call it gastroenteritis, but actually we don't know. We just know that their workup was okay. I would caution and counsel people to avoid committing to a diagnosis if you don't know. It's okay to just say it was abdominal pain. And here are the reasons you should come back. And you have that discussion with the patient and you write it down. You can have kind of a long heart-to-heart with the patient and make sure they understand and be like the best doctor. But if you don't write it down, it's almost like it didn't happen. And that's not just from a legal standpoint. Like, we know that they're not retaining a ton that you're having with them verbally. So you've got to do both parts to really, do right by that patient. And then, when you do that, remember that on average, these patients are communicating at about a 6th to 8th grade level. So you've got to keep it simple. My general recommendations there are don't overcommit to a diagnosis, because that can really pigeonhole you. And then people get frustrated appropriately that they didn't have kind of the full picture in mind. Whatever you're communicating to the patient in the room, that's great, and do that. But then you got to document the same thing so they, really have a chance to understand and read at home what you said, let their family see it, whatever. And then keep that communication really simple, 6th to 8th grade level.
As I was preparing for this discussion with you, I was thinking about adding another one, and I'd love to know what you think about that. And that is document whatever's still pending, and then also whatever the plan is to close the loop on those things. I'm assuming that is in line with everything that we've been talking about.
Yeah, I think absolutely. If they're going to get a phone call or we're following on their urine culture or something, because I think one of the reasons that's so valuable is we think that they're going to get a phone call, or, we think that we're going to send this antibiotic to the pharmacy, but if it doesn't happen, it helps them to be able to help close the loop on their own end, or let us know if, it's just one more safeguard if things didn't go as planned. So I absolutely like that and think it should be added.
I love hearing all your examples for things. Do you have any examples of how discharge instructions were like the focal point of the litigation?
Depends how you want to be scared today. One of them, again, that I think you could all see ourselves in the situation, most places now with these EHRs have templated discharge instructions, which are great. A lot of these you can use without changing. One of these led to a tragedy. There was an elderly woman who came in and she had hypokalemia and was thought to be secondary to some of her meds. She was discharged home after this was corrected with discharge instructions that were supposed to be for hypokalemia, but they inadvertently gave her discharge instructions for hyperkalemia. And she followed those instructions to a T, and she died. So it ended up with a $100,000 settlement. It would have been higher if she wasn't elderly, presumably. But, that is so easy to see how that could happen in a rapid-paced emergency department. Another one, a woman went to an urgent care, and she had shortness of breath and an elevated D-dimer, and the physician said, you've got to go to the ED to get this taken care of because I can't get a CTA here. So sent her to the ED. The woman didn't go to the ED. She went home and she died. And her family sued saying, like, what terrible care is this? She had shortness of breath and elevated D-dimer and you sent her home. And the doctor said, no, I didn't send her home. I sent her to the ED. But her discharge instructions just said shortness of breath. And there was nothing on there that said go to the ED. So again, I think we all believe that this person had the appropriate discussion, but it was not documented. And she's ended up settling for $2 million. You absolutely have to document it. And another one, there was a baby who was born prematurely. She had retinopathy of prematurity. So it was important that she go see an ophthalmologist pretty shortly after discharge. She was set up specifically to see a certain ophthalmologist. They sent the baby home with the mother, told the mother to go follow up with this one. When she called to make the follow-up appointment, that ophthalmology office was closed, not taking patients. So the mom called around, found another ophthalmology appointment like a month out. By the time she took the baby there, baby was blind. She sued and said, nobody ever told me this was like urgent that I do this. I did my best. You told me to follow up with an ophthalmologist. I found one. Like nobody communicated that to me. And, this isn't an ED setting, but I think we can all understand the lesson there that just saying, go follow up with this person is not enough. You have to communicate to the patient why, the timeline, all of that, and not just communicate it, document it, because otherwise we could end up in that boat too.
We've talked about a lot of high-risk situations, AMA, incidental findings, these results coming back. If I perceive that I'm entering into a high-risk situation, what kinds of things can I do to protect myself?
It's a bit of a loaded question. I like to think about this for patient encounters where you just feel bad about them. Like you can tell that this family doesn't like you, the patient doesn't like you, things are not going well, there's going to be a bad outcome. Like you just leave that room and you kind of get that ick feeling. Is there anything you can do in that moment to make it less likely that they're going to sue you should things go bad? It almost feels too late, but I do think there are some steps that you can take or maybe things that you should avoid that will be helpful for you. Here's my list of things you should do. First of all, despite all the things we've been talking about, I don't write long notes on patients. But these are ones where I spend a little bit more time with the note. So I would say you have to be real sure that you're kind of fully and accurately documenting what you did with that patient. And one of the points with that is, let's say this patient, came in with shortness of breath and then halfway through their ED stay or while they're waiting to get admitted, they develop chest pain or something. Sometimes I hear feedback that physicians think they can't go in and edit a note after it's been signed. They think that they're going to get in trouble for that because we've heard that, right? Can't change your note. But with these patients, it's super important that you're giving the full story in the note. So know that not only, can you, but should you document fully what happened to the patient. And the way to do that, if you're worried, like if this patient had a bad outcome and something changed partway through the stay, you'd already signed their note, whatever. The way to do that is to take the note that you already wrote and then addend it and just be explicit about what you're adding to it. So you're not maybe going back through and changing what you wrote before. You're not deleting stuff, which would be really easy to see in metadata, but you're just kind of adding an addendum and saying patient had a change of course and writing that out. So don't be afraid to kind of add to patient's notes at any point. And if you're worried that it's going to look fishy because something changed about the patient, just be explicit that this was something that you're adding after the fact. Another thing you can do is document others' involvement. So if you had consultants involved, maybe you're waiting for them to drop a note and they haven't done it yet, you document that consultant's involvement. And don't just say cardiology was here or something. Put the initials of the person involved so that that can be tracked down later, because that is a really common theme that becomes problematic for a lot of people in our specialty in cases all the time. So if other people were involved in your decision making or that patient care, document who they were by name or at some type of identifier. Same thing with chaperones, because you don't want to get into a he said, she said with the patient. That can really help you. Another thing that can be an issue and does come up commonly is that sometimes you'll see a discrepancy between the note of a nurse or a note of a trainee, and lawyers love that. They love to say, well, look, the trainee said that the patient was in respiratory distress and the attending said no respiratory distress. Obviously, the attending wasn't paying any attention. The nurse said they had neck pain. The physician said they didn't. Obviously, the physician didn't do a good exam. That's how they use that. And so you don't have to chase everything that's in the nurse note or the resident note, but you should at least acknowledge it and say, you know, I see the triage note says X. I evaluated that piece and I either agree or disagree. You should probably do that for every patient. I won't say that I do, but for these patients where you're worried about them, it's worth going back through the chart and making sure that you're evaluating for any discrepancies so that you're avoiding that situation, because that's one of the things that lawyers are explicitly taught to look for, is any discrepancies between nursing notes, physician notes, resident notes.
Is there precedent for how nursing and physician notes are evaluated by courts?
I can give you a couple examples of this. So first of all, in this book called The American Jurisprudence of Facts, which is basically where lawyers are teaching, you know, other lawyers how to bring malpractice cases. They basically say this is a great strategy to demonstrate that physicians are not providing good care in malpractice cases. And I pulled out a clip from that where they're saying this is something you can look for. They say, the value of recognizing the difference between a brief note of a busy physician and the more leisurely and fuller account of a nurse working an 8-hour shift and virtual constant attendance on the patient should be readily apparent. Cast in the proper light, the nurse's notes may well be given more credence by a jury when confronted with a conflict, reflecting significantly on either the client's injury or the question of liability. So they basically say, look for that, paint it as if the nurse is, you know, the one who's right, and you know, you'll have your case. And I can give an example of a case where that happened. Basically, a patient came in, he was drunk, he'd been in a car accident, and he came in and the nurse triage note said he had neck pain. Doctor that examined him thought he only had hip pain. He got a hip x-ray. He got discharged home with a friend or something. And when he woke up the next day, he had some right arm weakness, and it turned out he did have a cervical fracture. The physician didn't document anything about his neck pain, and they basically went back to the nurse's note and said he had neck pain. And the physician said, no, I did a neck exam. He didn't have any neck pain. And they said, well, obviously, you know, triage note said he did, and you didn't document anything in your chart. That was explicit. I think he just had like a templated physical exam. So that's basically how they use it.
Going back to your guidance in general about documentation, you talked about things that we should do. Are there things you think we should avoid?
Yeah, so there are some ways that we seem to get ourselves in trouble pretty routinely that I think are really easy to avoid, so worth pointing out. One of them is that we see some errors with people copying and pasting, not infrequently. And this is really tempting when you have really complex patients that had, you know, surgeries we can't pronounce or hospital stays that lasted for days, where it's tempting to copy and paste that into a note. But it can cause problems because you might say, you just had this hospital stay a month ago, you copy and paste into your note, but now you're telling people this is post-op day 3. And it's not, because that was a month ago. So you can harm the patient that way. And also it's lazy, you know, and we understand it, but lawyers, the way they're going to spin it is that you're lazy. So you get in front of a court and you're like, did you write this note? Well, no, I copied and pasted it. So again, if you have a patient that you're worried about, an encounter you're worried about, an angry family, this is not the time to copy and paste and, you know, potentially give a lawyer an opportunity to say that you're not doing your own work and you're copying and pasting. So I would be very careful about doing that. Second, I try to make an effort to avoid details that don't need to be in there. And I think there are a few things that fall into this category. First, I see lots of quotes in notes that I don't think serve a purpose and sometimes come off as disparaging, and I think we can do a better job of avoiding those. Some examples that I've seen, recently are, patient says they have, quote, the sugars and their glucose was high. That serves absolutely no purpose. You could say patient is type 2 diabetic, but to quote them as saying they have the sugars is just kind of making fun of their vernacular or their level of understanding. It serves no purpose at all. And a lawyer will see that and can ask you about that. Why'd you say that? No matter what your answer is, the jury will see through that, right? The only thing that's going to do is make you look bad. So you have to think really carefully about why you're writing what you're writing. If you're doing it to entertain the hospitalist, it doesn't belong in there. There's a lot of good literature too that we as clinicians use quotes more often for people of color, people with disadvantaged backgrounds that, we are guilty of using that to disparage people. So not saying quotes never serve a role, but we have to be really, really careful about how we're using them and if they're necessary. Other details I pulled from a note the other day, patient was at a Trump rally. Regardless of your political affiliation, if something goes wrong with that patient, that's not something that's ever going to help you, and it can definitely hurt you. So some of those details just don't belong there. You want to say they're at a political rally because maybe that's relevant to their history, fine, but it doesn't need to be any particular politics mentioned in the note. So I'd be very careful about that too. Another thing is using templates to make your involvement look more robust than it was. So we see this in the clicking of the template for the 10-point physical exam or review of systems. Patients are now seeing these charts basically immediately, and they're going to know, did you look in their ears? No. Well, then why'd you chart it? This can be super inflammatory. There have been studies on this that show that basically half the time our charting is fraudulent because we're using these templates. So we have to be really, really careful about doing this. We should be careful about it all the time. But if you have a patient or family that's already upset with you, documenting something that didn't happen is a way to incense them even more. And then, falsifying the chart in any way. This is something that should never be done. It's silly to think that people still think they can get away with this in the era of metadata and electronic charts, but it happens all the time. And there's huge consequences for that. Just to scare people again, this still continues to happen. I can see the temptation when it was like you're writing in pen and you could scratch it out or something. But now if you do this, like the computer saves everything. So we know when it was deleted, what it was replaced by, everything. There's really no way to falsify a chart and not be caught. But if you do this, not only do you automatically lose your credibility in court immediately, but in a lot of states, you can immediately lose your medical license. So, there goes your life for, your professional life. You can lose your malpractice insurance. A lot of insurance has riders that say that if you're caught falsifying the chart, your malpractice insurance no longer will cover you. So you're on the hook for the entirety of any claim against you. And then you can be open to punitive damages. So there are states where they don't allow punitive damages in malpractice suits, but this can be an exception to that. If you're caught falsifying the chart, then you can be open to those. So those are the ones where you see those, bazillion-dollar lawsuits. And this is a way to get yourself subject to those. So can you imagine losing your license, losing your malpractice coverage, and being open to punitive damages just because you tried to cover up a mistake? It's just absolutely not worth it in any way.
So, Rachel, this has been incredible. I always learn so much from your talks, and I would encourage all of our listeners, if you see Rachel's name at a conference, go to that talk. For our listeners, if you had to sum up and give them a couple takeaways, what would you say?
Well, I'll try to boil it down to a couple. First of all, you have to be a good clinician. Follow accepted clinical practices, especially for those high-risk clinical conditions. You're not going to get yourself out of risk by doing anything but the right thing clinically. So you've got to know standard of care and you've got to follow it. You have to document what you did. I think for the most part, people are practicing good medicine, but if you're not documenting it, you get yourself in trouble. So, document what you did, especially for kind of the cases that we've talked about, those instances. We need to assess and document capacity more often. Don't be afraid of that. It's not a complicated thing. It's like 4 elements. If you're doing it right, it just takes a couple minutes. I think once you start doing it, it becomes a lot easier. So I'd encourage everyone to make that a part of their daily practice. provide appropriate discharge instructions, and remember that that's really a continuation of our care. It's not an afterthought. Ensure that you have a system for following up on delayed results. Again, that's a part of the process that we should own. And as people are maybe leaving more often than we'd like, earlier than we'd like, we have to own that part of the process too. And then I think really it just boils down to caring about your patients. I think you'll do all of these things naturally if you really care about what happens to these patients. You're going to provide them good care. You're going to talk to them. You're going to make sure that they're on board with everything you're doing, and you're going to make sure that they understand what should happen after their care. It's just going to come naturally. So if you care about them, this will just be kind of normal.
The best interest of the patient is the only interest to be considered.
There you go.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamconda.